basic case presentation. So, a young 60-year male presented without any systemic symptoms. Patient was diagnosed to be stage 4 NSCLC with a lung lesion. The patient was initially started on treated with platinum-based treatment, pemetrexed plus cisplatin, and after second treatment, after 2 cycles, follow-up scan showed stable disease. Patient's performance status was fine. At 12 weeks, it was found that the patient is having progressive disease. So a patient having rapid disease progression within 3 cycles of starting of treatment, patient had baseline EGFR ALK cross wild type, PD-L1 expression was less than 50%. So we see these type of patients in our practice. Around 30% patients are rapid progressors. What is the rapid progressor definition? Usually the patients who are progressing within 12 weeks of starting the treatment. That is important to understand, and this is what is required. So this is an important point which we tend to forget. We do not realize, but it is very, very important. Aggressive disease, identify it, rapid progression at 12 weeks or earlier starting the platinum-based treatment. So when treated with docetaxel alone, these patients who are progressing rapidly, these have very poor outcomes. This is only 5.8 months of PFS. While in the overall data, if you see the overall PFS in the intention to treat population, it is more than 9 months. So definitely 3.5 months of stark difference in the rapid progressors. So it is clear that the patients who are progressed rapidly on the platinum also progress faster on docetaxel based treatment as well. So what is important to understand, how many patients are actually rapid progressors, that means having aggressive disease biology. If we see, our experience is close to 30% in our practice. Now coming to Cyramza, we know Cyramza is a human receptor targeted antibody, and it is shown specifically to block the activation of VEGF receptor 2, and it was seen to bind directly to VEGF receptor 2 to block binding of all VEGF A, C, and D. So that is what we need. So this REVEL study, which we have seen previously, it is a large pivotal phase 3 design, randomized double-blind trial, which has for patients who have progressed after first-line platinum-based treatment. And major efficacy outcome measure was overall survival. Again, a very important point here, overall survival was taken as the endpoint, and other endpoints were PFS and response rates. So key exclusion criteria, it is similar with any VEGF-directed treatment. Patients with major blood vessel involvement, intratumoral cavitation, that is any chance when there is high chances of tumor bleed. And also the patients who are already having GI perforation history or fistula, or patient who are having thromboembolic event with the last 6 months, these are excluded. Also, gross hemoptysis within 2 months or grade 3-4 bleeding within 3 months were excluded. Also, major surgery within 28 days. So these are the basic things which we look before giving any VEGF directed treatment to our patients, and this remains same for this trial as well. So if we see the data, best response to platinum, and approximately 1 in 6 patients have rapid progressive disease. So that is very important. In these patients, you need to be careful. Even these patients are not going to do well on the next line of treatment, which is usually docetaxel. If we see the data of Cyramza plus docetaxel, this is the key demographic criteria, demographic functions. It is somewhat similar in both the groups, which is standard in the randomized trial. And you can see for intention to treat population, it was 5.8 months versus 9 months. So around 34% patients survived 1 year longer with Cyramza plus docetaxel, and this is for rapid progression patients. So definitely it makes sense if you can identify the patients who are progressing rapidly and utilize this drug at the correct time. So what happens? You can in fact double the progression-free survival. Close to doubling is important. So if we see the data, we want to compare the data of intention to treat population of the REVEL study. It was 9.1 month, and if you add Cyramza, it was 10.5. So it doesn't seem so exciting. But if you see the rapid progressive disease, you can clearly see the difference is stark. 5.8 months versus 9.1 months. So it is important to understand, you need to identify rapid progressors, to be precise, within patients who are progressing within 12 weeks of platinum-based treatment, and utilize them docetaxel plus Cyramza combination. And in intention to treat population, even in intention to population, even if you see the median values are not so starkly different, but in the hazard ratios, it is 43% patients are surviving 1 year or longer, which is commendable. So patients where there are rapid progressors, the absolute benefit is close to 3.5 months, and it is 57% improvement in the median overall survival. So median survival, which is improving by 57% in patients who are EGFR-L positive, negative. PD-L1 is also low. There we don't have many options, and there in those cases where we don't have much options, even in those patients, this drug is able to improve the survivals, and that is overall survival. We just had a small discussion on PFS versus OS, and in that case, we are seeing improvement in the overall survival by 57%. So that is worth commending and recommending. So if we see this data again, this is the values in the intention to treat population, PFS 3 months versus 4.5 months. And in patients who are having rapid progressors, it is increasing from 1.6 months to 3.6 months. So 1.6 months is hardly 2 cycles of docetaxel alone. And by adding Cyramza, it is actually improving to 3.6 months. So that is very, very important. So if you see, if you are administering docetaxel alone to a patient who has progressed rapidly post-platinum, most patients will progress within 2 cycles of docetaxel, and that is somewhat improved by utilizing Cyramza, and median PFS becomes 3.6 months. So this is very important to be noted, and the percentage also is significant. 10% more patients, it is more than double the exploratory subgroup analysis, the benefit in these patients of having overall response. So adverse effects, yes, we are very well aware of the toxicities of drugs like VEGF inhibitors, and this is somewhat similar, no much difference. Docetaxel is causing most of the myelosuppression, and F1 rates are also similar, not much increased, and so toxicity seems to be well balanced. And if any one of us has used Cyramza alone, it is not so different from that. It is the addition of docetaxel which is causing most of the toxicities, and we very clearly know how to manage that toxicities. And this is the additional adverse events to consider with Cyramza as antiogenic agents. Treatment discontinuation due to adverse effects occurred in around 9% patient, and it was 5% in docetaxel alone. So it's not too much different, and these it seems that it is well tolerated in our patients. And definitely this is the reason why in this particular case we would like to add Cyramza to docetaxel, because the patient is rapidly progressing. Patient is looking for having some response as an additional treatment, and there is no evidence of central location or major airway or blood vessel involvement, and there is no history of hemoptysis. That makes one of my patient an ideal candidate to add Cyramza apart from docetaxel. And also if we see the doses, Cyramza doses is 10 mg per kg, infusion time is around 1 hour. Docetaxel infusion also takes around an hour, and it is 3 weekly cycle, so you don't need to call the patients additionally, and it is very can be given simultaneously with the similar pre-medications as well. So this is the dose modification can be done accordingly. Only important thing which should be considered is hypertension and proteinuria, which we know for our patients with bevacizumab, and similarly with Cyramza, somewhat similar guidelines. And therefore we can consider Cyramza in these particular patients who are progressing rapidly within 12 weeks of start of platinum based treatment. So with this I stop here, and would like to take any questions if there are. Thank you. So another problem with nintedanib is that it has we need to be careful with the toxicities of nintedanib. We initially thought it is a good drug to inhibit pulmonary fibrosis. It was used in COVID time a lot, but our experience is somewhat different. If we see the TMH analysis which we have done, we have the data of around 25 patients who received nintedanib. The data is not so encouraging, and especially in the patients who are progressing rapidly, I don't think there is a place for that. Thank you. Thank you.